respected chairpersons, my teachers and dear colleagues, Assalamu alaikum. I am Dr. Tanveer from United Hospital. My topic of today's presentation is to punch or drill. What would I prefer? So it is about, not moving. Okay. It is about a 76-year-old fragile lady got admitted with chest pain for 2 days with previous history of stenting in LED and LCX to OM. She is known case of hypertension and bronchial asthma. Echo was fine, no regional wall motion abnormality, but troponin was quite high and other parameters were normal. This is the ECG. So we proceeded for an angiogram. As we can see, the first look was horrible. There was lots of calcium in it. And then we can see significant lesion in both proximal LED and LCX and instant lesions in both the stents. Significant calcium, more prominent in LCX. RCA was normal, that was a good thing. And it was a codominant vessel along with LCX. So what's the plan now? The problem is in hand. It is a very fragile lady, 74-year-old with ongoing chest pain presented with non-STMI. And we are dealing with heavy calcification, double vessel disease, having involvement in proximal LED and LCX. So the options in hand, PCI or CABG. And the patient's attendant, with a thorough discussion, they opted to go for a PCI. So the challenges which we are facing were the involvements of ostium, both LED and LCX. So we decided to take help of imaging. And to deal with calcification, we kept cutting balloon, IVL, and rota in our armamentarium. So first a BMW wire was taken, and as we can see, the IVUS was not crossing the lesion. So we took a 215 balloon, tried to dilate the lesion, but the ostium could not be dilated. So what now? The problems were it is a MI setting and we had instant lesions as well. So we considered to punch the lesion using an IVL rather than to go for drill by rota. So we took a 2.5 12 shock wave IVL balloon, inflated at 6 ATMs and started giving the pulses, both of 10 waves at a time. As we can see, during giving the shock waves, there are spikes arising in the ECG, which suggests that the shocks are delivered successfully. So after that, we dilated the lesion using a 312 NC balloon. And then we did an IVUS. Still, it was not fully dilated. So we again dilated the lesion using 315 and subsequently with 3.58 balloon in the ostium. And then we repeated the IVUS. We showed the LCX was dilated to satisfactory level. Then we concentrated towards the LED. We did the IVUS where we can see the LED in the proximal part was also stenosed with quite good chunk of calcium. So we used the IVL balloon again in LED and then post-dilate, and then we dilated it with further with 3.5 12 NC balloon. After pre-dilatation, we repeated the IVUS in LED where we can see the calciums were fragmented and there were reverberation shadows. So now what should be the technique we'll be dealing with? We have both the ostial LED and LCX, codominant LCX as I've said. So we decided to go for double stent strategy using the DK crush, which suggested better outcome in recent DK crush 5 trial. So we did the ostium dilatation again using 3.5 balloon in both the LED and LCX. Then we put in stent in LCX and we kept a balloon in LED, inflated the stent in LCX and did the first crush using 3.5 15 balloon in LED. Then we did the rewiring using a BMW wire through the proximal stent struts, as we can see in the angiograph view. Then we did the first case using 3.5 15 balloon, inflated it simultaneously. And then we took the second stent 3.5 24 from left main to LED. As we had done the IVUS earlier, the stent size and the lengths were guided by the IVUS. And then inflating the stent in LED, we did the second crush. We did the pot using 4.58 balloon, then the LCX was rewired again. We took 3.5 balloons, we did the second case. And then we did the report using 4.5 balloon. And then finally we did the IVUS, the MLA in proximal LED and LCX, and then in left main were satisfactory. So this is the final angiographic view which was satisfactory for us. And so the final take-home message for me, when we are dealing with complex calcified lesion, imaging, it helps to reduce time and selecting proper hardware. Proper planning and tools is a must while dealing with calcified lesion. And bed preparation must never be compromised before we place a stent. Importance of post-stent MLA by IVUS is going to determine the long-term outcome, so it should always be checked. I would like to thank my mentor, and finally, IPDI for giving us the chance to present such a case here. Thank you, sir.